our collaboration webinar with the Malaysian Spine Society. So today we unite to enhance our outstanding on the treatment of the spinal condition and driven by our shared pursuit of excellence. So our webinar entitled is a decompression techniques in L45 bilateral subarticular stenosis. And this is a represent a challenging conditions characterized by narrowings of the spinal canal and often resulting in the debilitating symptoms such as back pain, leg pain, and neurological deficits. And also the intricacies of this pathology demands nuanced approach and innovative techniques to achieve the optimal patient outcomes. So together, our societies have a creative panel of esteemed experts who will share insights and experiences in addressing the challenge of L4-5 bilateral subarticular stenosis by exploring the effective decompression technique to specific condition, and we aim to enhance surgical outcome, alleviate patient suffering, and of course improve the overall quality of life of the patient. In this moment, I extend sincere gratitude to the Malaysian Spine Society, especially to Professor Christian as a president of the MSS for their partnerships and organizing committee of this event. This is symbolizing the spirit of collaboration within our community. And to our participants, I encourage to active engagement, question, and sharing perspectives. Of course, your contributions enrich our dialogues and collective knowledge. So, let us seize this educational opportunity to learn, to exchange ideas, and foster friendship across border. So may our webinar be informative and inspiring and driving advancements in spine surgery and our patient cares. So thank you for joining us, and please have a great day. And also thank you to all speakers who share your time and your knowledge today. And again, thank you to all committees. Good morning and thank you. Thank you, Nadia.
Thank you, Dr. Gustilana. Esteemed participants, we shall begin our first MSS PCI IOSS joint webinar shortly. Hereby a brief housekeeping reminder. Kindly mute your microphone during the case presentation and lecture to avoid background noise and sound interference to the presentation. During case discussion and Q&A session, you may use the raise hand function or the chat function on the right of the screen. The moderator of the session will call upon you and you may unmute your microphone. With that, we shall now begin our webinar now. The webinar program today will begin with case presentation, followed by a series of lecture before we return to the case presented to wrap up what was done. Without further ado, I would like to pass the hosting to the moderator for the case presentation, Dr. Nur Aida. Thank you.
Thank you, and I would like to welcome everyone to this first collaborative webinar between MSS and the Pedicle Club Indonesia and Indonesia Orthopedic Spine Society. So I would like to invite Dr. Satur to present his case, and we will continue with the other presentations after that. Dr. Satur?
Thank you. I'd like to share my screen first. Good morning. I am Dr. Sadurvedan from University Malaya. I would like to thank the organizing committee for the opportunity to share a case during this joint webinar. I have no disclosures. A 65-year-old lady with underlying diabetes mellitus, hypertension, transient ischemic attack, and poliomyelitis with residual left lower limb weakness presented with bilateral L5 radicular pain for 6 months. The pain was aggravated by prolonged standing and walking. It was associated with bilateral leg numbness and weakness. There was no back pain or instability pain. She was able to ambulate with walking frame. There were no central anesthesia, urinary or bowel incontinence. On examination, there was no spinal tenderness, no paravertebral spasm, no deformity. There were left leg muscle wasting with pes cavovarus deformity. Lower limb distal pulses were equal with good volume. Neurological examination on the right side was generally normal, except for EHL for MRC3. On the left side, she has residual weakness post-polio. MRC4, except for EHL, which was MRC3. Sensory was generally intact, apart from L5 bilaterally was reduced 1/2. The reflexes, left ankle reflex was reduced. Lumbosacral X-ray shows spondylolisthesis grade 2 L4 L5 with L4 L5 vertebral body sclerosis and end plate sclerosis, reduced intervertebral disc space over L4 L5 L3 L4, no fracture, pedicle erosion or end plate erosion were noted. Dynamic view shows no translation over L4 L5. Change in this angle was 2 degrees. MRI shows degenerative listhesis L4 L5 with bilateral L4 L5 foraminal stenosis. On axial cut L3 L4, there were narrowing of spinal canal, facet hypertrophy, hypertrophy of the ligamentum flavum. However, there were no compression of traversing L4 nerve root bilaterally. L4 L5 axial cut shows narrowing of spinal canal, bilateral subarticular stenosis with compression of bilateral traversing L5 nerve root, facet hypertrophy with minimal facet effusion. CT scan shows vacuum sign over L3 L4, L4 L5 with vertebral body sclerosis, L3 L4 axial cut and L4 L5 axial cut shows vacuum sign. The diagnosis was degenerative spondylolisthesis L4 L5 grade 2 with bilateral subarticular and foraminal stenosis. I will share what was done during the next presentation. Thank you.
Thank you, Dr. Satur. So we'd like to start the series of presentations. The first would be open microscopic decompression for lumbar canal stenosis. The presenter would be Dr. Roni Eka Saputra from M. Jamil General Hospital, Padang, Indonesia. So any questions, you can write in the chat box or ask and after this presentation. Dr. Roni?
Good morning. Thank you, moderator, to invite me in the webinar series. This is the first time MSS PCI IOSS collaboration I'm very happy to present my case. My case about the open microscopic decompression for lumbar canal stenosis. I'm from Andalas University. I'm Jamil Hospital, Padang, West Sumatra. This is we have a randang. Maybe my friend from Malaysia like the randang. In the West Sumatra is the very famous traditional food. Okay, disclosure. I have no financial disclosure or conflict of interest. Introduction. Lumbar canal stenosis is a cauda equina compression in which the lateral or anteroposterior diameter of the spinal canal is narrow. It is defined as narrowing of spinal canal, nerve root canal, or vertebral foramina. And my case, female, 59 years old, back pain and leg pain, numbness, and have be diagnosed with the lumbar canal stenosis L4-5. We see the X-ray. This is see the narrowing of the vertebral 4-5 vertebral disc, and we check the dynamic view, the listhesis of the L4-5. And after that, we check the MRI. We see the bulging of the vertebral disc, L4-5 disc, and thickening of the ligamentum flavum. And we see the axial view. We see the thickening of the ligamentum flavum and hypertrophy facet L4-5. So we do with posterior decompression with microscopic surgery. We open about 3 until 5 cm incision in the wound. After that, we expose from the L4 and L5 lamina, and then advantage of microscopic surgery is maintaining stability because we don't remove out the facet joint, and fully excising the ligamentum flavum. And we usually use diamond tip high speed drill. This is the intraoperative from the microscopic surgery. The patient placed in chest position, and the surgical exposure with the retractor, and maybe approximately 4 until 5 cm skin incision with a single level decompression. The more cephalospinosus process is cut on an angle with suitable instrument, then swing out the way while preserving the interspinous ligament for the reattachment of the time of closure. The caudal 30 until 50% of the central lamina is removed with a large 4 mm diamond burr, progressively undermining the dorsal cortex so as to maintain the integrity of the posterior arch. In essence, in removing the cancellous bone and the ventral cortex which overlies the ligamentum flavum. The extent of osseous decompression may extend to at least far cranially as a region of the ligamentum flavum. The extent of the entrance zone of neuroforamen. Ligamentum flavum provides a protective barrier between the burr of the dura can proceed safely its margin. And we sold protective instrument with the nerve retractor, and we check with the smaller diamond burr. Addition often present between the dura and underside of the lamina. It might lead to dural tear. Be careful to dural tear. The separation cranial and lateral margin of the ligament is complete with 2 mm Kerrison ronger and angle curette. The next step addressing to lateral attachment of the ligament flavum to the facet joint. The medial 2 until 3 millimeter inferior of the inferior arterial process is removed on the trajectory angling ventrally and laterally, not directly in the sagittal plane. In this angle, recession helps maintain the function and integrity of the facet joint. The medial portion of the SAP and associated osteophyte may then be cut away with 2 millimeter Kerrison ronger and maybe with the angle curette. Epidural vein may control with bipolar coagulation. The exciting and traversing nerve root on the other side should be careful, inspect for indication of persistent stenosis. After that, the lamina portion of the ligament flavum was attached to the superior and the inferior lamina. Detached cranial about 7 millimeter superior to lower body of the lamina, and caudal about 2 millimeter inferior to upper border of the lamina. So this is the after we remove of the ligament flavum and block the canine ligament flavum. So this is the incision wound, and maybe patient very happy and can move and walking without numbness, without radiculopathy symptom. Thank you. Thank you very much. Thank you, moderator.
Thank you, Dr. Ronnie, for your presentation. Excellent presentation. There is a question for you from Prof. Christian. How do you perform bilateral laminotomy or laminectomy? Dr. Ronnie?
Well,
And Dr. Ronnie? Dr. Ronnie, are you still in the? Can you hear us?
jadi saya turun dulu baru kamu
I think there may be a technical problem. In that case, let me try again, Dr. Ronnie. Okay, perhaps we will come back to this question later. So we move on to the next presentation. I would like to introduce you to my co-host, Dr. Yuta Madan Sakti from Indonesia, to continue with the moderation.
Okay, Dr. Aida, very pleasant and nice to see you again.
Yes.
Apologize, I think Dr. Ronnie may be having some technical difficulties. We are trying also to contact him. Again, appreciate Dr. Aida. So we are now moving to our session now, Dr. Aida? Or should we wait? Okay.
Maybe if he's going to come back on, we can wait for a little bit. If not, we can move on.
Continue.
Yeah.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. I appreciate the collaboration of between PCI, Pedicle Club Indonesia, Indonesian Orthopedic Spine Society, and our brothers and sisters from Malaysia Spine Society. Hopefully, this will be a good way to start further, more fruitful collaboration, Dr. Aida. So we move on to the next session. We will call upon our senior Professor Dato Muhammad Hisam M. Arifin from UKM that will tell us about the microscopic tubular unilateral laminotomy for bilateral decompression. Maybe also answer a little more about the question from Professor Chris asked to Dr. Roni. So can we call on Professor Hisam to join, Associate Professor Hisam to join and give the lecture?
Yes, thank you very much for inviting me. So the Secretariat will play the video for you.
Approach. Assalamualaikum and good morning. My name is Dr. Hisham. Thank you for having me at this webinar, and I shall be presenting on tubular retractor assisted bilateral decompression through a unilateral approach. And in this presentation, we actually use a microscope to have a bilateral decompression of both the central and the subarticular stenosis using a unilateral approach. Basically, it consisted of a laminotomy on the access tube side to provide the decompression on the ipsilateral side, and over the top laminoplasty to provide the decompression of the central and the subarticular stenosis on the contralateral side. So the indication is actually central stenosis with presence of radiculopathy, either unilateral and or bilateral. It's best done for patients with predominant leg symptom. You must have a stable motion segment. In case of spondylolisthesis grade 1, it has to be a non-mobile or a stable type of listhesis. You have to have a good disc height, meaning there is no foraminal stenosis. You need to have a flat facet joint angle, means the facet joint angle should be flat, so that when you do the subarticular or lateral recess decompression, you do not create an instability, and it is best done when you have a predominant dorsal compressive pathology, which is usually from the thickened ligamentum flavum, and then also the facet joint hypertrophy. So this is a good case that you want to begin with. You can see there very good disc height, stable type of spine as evidenced by the osteophytes, anterior osteophytes, and the stenosis is central, but it's more on the right side on the axial cut MRI, and this is how it's going to look once you finish the decompression. There is the contralateral side neighborhood that I'm going to expose now, and then you can also see the ipsilateral side of the neighborhood exposed. When you have the facet joint angle acute like this on the MRI, you know that the shaded area now is the area of the decompression that you have to do. You may create an instability, and therefore in this kind of cases I would do instrumentation for them. All our patient is positioned in prone, and to recreate back the lumbar lordosis so as to mimic the lordosis of the lumbar spine when they are walking. When doing this, we ensure that we will remove adequately all the compressive pathology, as you know that this kind of central stenosis is usually dynamic in nature, and more symptom is produced when the patient is walking. By mimicking the position that they are upright or walking, we can always ensure that we have removed adequately all their compressive pathology. This is how we set up our operation theatre we use the microscope in an exoscope mode. The C-arm is positioned in lateral view and can be moved freely to check if we want to do an intraoperative X-ray, and this will minimize the movement of all your gadgets during the surgery. When using a skin marking, you have to know that the target determines the location of the access, and you want to put your access, which is the tube, as parallel to the target as possible. After we have marked the level that we want to do the decompression, we will palpate the spinous process, and our incision is just lateral to the spinous process. Okay, in this way, our tube will be placed just beside the spinous process. This is in contrary to what is described in the usual textbook for this tubular approach, where they put the tube around 3 centimeter from the spinous process. We find that by placing our tube directly beside the spinous process, our wanding is actually less, and we can actually see the contralateral side better. During the approach, you want to cut the lumbodorsal fascia as seen here, longer than you access. So now we are palpating the spinous process and cutting the lumbodorsal fascia, which is actually longer than the access. Why it need to be longer? So that you can easily wand your tube. You don't want your fascia to restrict your tube
Excuse
movement.
me.
Then you put the serial dilator and use the serial dilator as just like a periosteal elevator or a cork, and then you put your tube inside. What is the best size tube that we want to use for a decompression? Usually you will use around 16 to 20 size tube. I found that if you use a size 20 tube, you will actually, the lateral edge of the tube will actually be hinging on to the facet joint. So when you begin, it's much easier to use a 20 tube, but try to migrate to a smaller tube so that you can avoid the injury to the this is what you actually see, the small fat there.
I'm sorry, Dr.
Your
Hisam.
left underneath already.
Apologize,
So
Dr.
the
Hisam.
base of the spinous
Okay.
process, and this is how we use the burr.
Can you hear me?
Yes, the video is having a rerun, so maybe yeah, you can replay it a little bit,
I
and then
can
we
share
can
it
go on.
for my phone.
Yeah, now we can see. Now we can see. Yeah, thank you,
Okay,
sir.
okay, good.
And
Okay.
then to the near base of the spinous process, and this is how we use the burr. Don't
Excuse me,
want
but
to
the
use
video still
burr
still
and
seem to
not
be stuck at one place.
Oh yeah, yes, it's stuck again now.
if you
Is it possible to put it again, sir?
Can I share it from my screen instead?
Yes, yes, of course. Again, apologize for all of the viewers.
Yes, I'm sorry. I make the video so that this won't happen, because sometimes the internet connection is not good. But then I'm very sorry.
It's okay, Professor. if it is all right with you, can we call
Can I
upon
join
Dr.
from my computer instead?
Yes, of course.
Okay, I
Can
join
you
from my
share it now?
computer.
Perhaps while waiting, Dr. Ronnie is back. There is a
Yes, can
question.
you please
I'm
answer?
here.
Yeah. There is a question for you, Dr. Ronnie, from Prof. Chris. How do you perform bilateral laminotomy or a laminectomy?
Pardon? Sorry, can you repeat again the question?
There's a question from Prof. Chris. How do you perform? Do you perform bilateral laminotomy or a laminectomy?
I perform the laminotomy and upper and lower of the lamina. If the kind of stenosis is the L4-5, we cut the small and the lamina L4 and 3 millimeter for superior of L5 lamina.
Do you perform it bilateral? Is it a bilateral? Or is it just
bilateral. Bilateral. I cut the interspinosus ligament.
Okay.
Because the stable, no, I have listhesis.
Okay.
Thank you.
Thank you.
Thank you very much, Dr. Aida. Now we can and Dr. Ronnie. If there's no follow-up, Professor Hisam,
Yes.
can you now share the screen
Great.
for the video?
I cannot seem to log in from my computer.
Okay, it's okay. Professor Hisam, is it all right with you if we call upon Dr. Nurul Azwa before?
Yes. You carry on.
Yeah?
Carry on first. Carry on. Sorry, I'm sorry.
It's okay, sir. So hopefully you can join after this, sir. Dr. Nurul
Yes,
Azwa.
I'll do that.
Yeah,
I'll do
Isam can join after this, Dr. Isam.
Yeah.
Thank you, Azwa. Thank you.
Yeah, again, Dr. Professor Hisam, we will be waiting for you. Now we will call upon Dr. Nurul Azwa. We see the dry decompression. Now we will go from the wet side, I think, Dr. Nurul Azwa, doing the endoscopic.
Yeah,
So, we give the time to Dr. Nurul Azwa to give the presentation. Please, sir.
Okay, first of all, I'm Dr. Azwa. I'm practicing in private hospital KPJ Ampang Puteri. I'm in Klang Valley itself. Dr. Isam is my colleague. But before I proceed with this endoscopic approach, I just want to mention that Dr. Satur case basically is not suitable for my techniques. Okay. The indication basically the same as what Dr. Isam initially presented. It has to be stable. There is no translations. And then basically the positioning, everything nearly the same. But the approach is just more minimal. We get the secretariat to play my video. Can we do that, Aida?
Yes. Wait a minute.
Okay. But between endoscopic approach and tubular microscopic approach, result after a while they are the same, but it just a little bit benefits in terms of cosmetic wound, and then few after the immediately post-operatively. That's the main benefit. There are certain limitation, and I will mention in the presentations.
Good morning, everybody, and thank you for inviting me to this collaborations between MSS and Indonesian's spine group. I'm Dr. Nurul Azwa. I'm practicing in Kuala Lumpur itself. Yes, today we're going to discuss about techniques for decompressions for bilateral foraminal stenosis. And my specialty is in the endoscopic work. So basically, I'll be talking about unilateral approach for bilateral decompressions or over the top decompressions endoscopically. Okay, a little bit of disclosure from me. I'm currently faculty for Johannesburg and faculty for Avanos. But however, for this topic, there is no financial interest or affiliations going on for these conferences. Okay, we already know there are some benefits that existed between endoscopic work and open techniques, and my colleagues already talked about these other tubular techniques for under MIS group. But the most apparent benefits for young and athletics is they can manage to get early mobilizations, and most of the time I can do as daycare surgery. They can get back to return to work earlier. And for the elderly, also there are some advantages where for multi-morbid, most of the procedure I do under spinal epidural, okay, and for obese patients, definitely it will give the most advantages because the wound, the excess surgery is very minimal. Then there is very minimal traumatizations, and there is no in terms of long-term sequelae due to conventional surgery, which basically we talk about scarring over the epidural space. Apart from that, the other benefits that we talk about is, but in comparing discectomy, yes, the mean operating time for fully endoscopic work should be lesser than minimally invasive because it's only to get out the discectomy. There is minimal flavum detachment. But in terms of stenosis or foraminal decompression, bilateral subarticular decompressions, the working length or the working time is longer compared to the minimally invasive technique due to the instruments are much smaller. Okay, but anyway, both benefits for decompressions, there is minimal blood loss, no drainage required, and then resecting the bony works done is very minimal to preserve or to, we know that when we achieve enough in a fully endoscopic group, okay, in comparison to the other technique is bigger bony works, but it make it faster because the use of bigger instruments. And then the other disadvantage of the fully endoscopic work is completeness of ligamentum flavum is better in minimally invasive or open techniques. However, VS back pain significantly reduced in endoscopic work. And in long term, they are the same between MIS and endoscopic work. The most limitations in terms of doing this endoscopic work is it takes a lot longer time in terms of to get the learning curve, to get used with the hand, coordination of the hand, and to get use of the view. So it is the main drawback. And then in terms of limitation, also it goes to the when I do for my patients, they are mainly cater for the leg symptom, which significant compared to the back pain. Okay, and it has to show that there is no sign of segmental instability. Talking about endoscopic itself, there are still limitations. Which one should we use? Whether we're doing the interlaminar or to combine with transforamina for completeness of decompressions. Okay, now we start talking about the surgical technique or decompressions for interlaminar uniportal endoscopic decompressions. So first of all, I would like the audience to know that interlaminar approach come from the interlaminar part, which is basically we approach on the midline, next to the midline. However, for transforamina, it comes from the sideway, normally about 12 to 13 centimeter away from the midline. So the next slide is, this slide is to show that at the end of the day, what we want to achieve is bony work is like this, where we decompress centrally, we cut and go to the other contralateral part, and some part of the SAP already taken out. And this is how we do. Initially we approach as ipsilateral, and then we will tilt the endoscopic to go to the far lateral on the contralateral side. And the capability of this, the big thing about this technique is because the endoscope can we can manipulate to go around interlaminarly over the epidural space. We can tilt between medial and lateral axis, as well as caudal and cephalad axis. So that's why the reason that we can have a better clearance in terms of view for these decompressions. Again, this slide is to show that taken out of the either laminotomy or fully laminectomy, and then burying over the preserving this area in terms of taking it the bony work, so that pulse is preserved between this, and this one is to show that how we can cut the SAP, superior articular process. Okay, this slide is just to show that there are few so-called scope that I use because the interpedicular distance changed from 2.5 centimeter, it goes to 4 centimeter between pedicle. So therefore, I use different type of scope. Sometimes to make things faster or lots of bony work, there are two type of scope that can be used. One is for 4.7 diameter working canal, or the other one 6, which is 6 millimeter, which we can use a bigger burr. So as I said, that this basically to show there are three types of scope that can be used. All interlaminarly approach, one-sided, and both can be done over the top. This first two is done as with the water flow, but this is a dry scope, which is what we call MED or the standout technique. Okay, in terms of positioning of patients, I commonly use a spine table for bony, for general decompressions. It's better because the abdomen left hanging. Can be done under general anesthesia or epidural anesthesia. Okay, the other thing is, if I use for discectomy, normally I use different table because I bend or I break the table, so interlaminar is a wider open up because I just want to penetrate the phlegm. But for bony work like this is totally different. So basically a step wound over the paramedian or the ipsilateral area, and then from there I just put a trocar in. So the slide over here is the what I commonly practice is the dry scope. The standout technique is a kneeling positions, like sitting positions, but now I just in totally prone positions. Okay, this is general OT setup for the procedure. the fluoroscopy is to determine the level. Normally, once I get the level, the fluoroscopy, I've taken it out. And then I normally on right side of the patients, and then I face on the right side of the monitor. Okay, this slide is to show that the approach is different between the decompression and discectomy. Alright, if I want to approach for discectomy, normally is angulated up, which is angulated cephaloidally. But if I want to do the bony work, the docking itself over the inferior part of the lamina of the next vertebra. So from here, because we're going to do a bonic work, it's much easier to go and cross over the intervertebral space. Compared here, I will tilt up. I'm going to tilt up to go to this area. Okay, this slide is just to show how to hold with single finger resting on the your patient, so to make it stable. Because sometimes under epidural they cough, everything near the dura they just cough up. This is surgical strategy, basically the technical things that you will do in your surgery. It's just the same, but a little bit adjustment under endoscopic view. First, irrigation has to be flawless, continuous. You have to make sure that water will come out from the trocar as well. Expose the interlaminar, clean up the soft tissue, make sure that you go to the lateral, clean up soft tissue from the superior and inferior lamina. Then you go and remove some part covering the flavum. You will go to the ipsilateral and cut some of the medial facet. And then from there you burr superiorly and inferiorly. You will expose or detach the flavum. Either you detach with the curette, as we like to do now, en bloc detachment of the flavums, or you can use the dissector to detach. And then from there you go up to the base of spinous process. You burr again until you are on the anterior part of the lamina. From there you detach from the dissector, or again using a curette. Then you can take carison out. This is done by tilting about 30 degrees to go to the contralateral side. This is what we call over the top. You basically see as if you are coming down to it directly. Once you've done everything, you cut the superior articular facet. Then you can trace the axilla and the shoulder of the nerve roots. And then you start mobilizing the root. Basically, you remove the osteophytes. The surgery is complete, and normally I don't put any drains. So this is the final result through the CT scan, where sometimes you can do a very wide clearance. Okay. Okay, this is to show that burring technique, where I go over the inferior part of the superior lamina. So you can see a small hole where some part of the flavum is being detached. And from here is a contralateral. I burr as well towards the other contralateral side. You see after a while you can see the dura here, and that's the edges of the dura there. Okay, this is when we do trying to get the flavec as en bloc flavectomy. Okay, removing the whole flavum as one piece. But normally I do half by half ipsilateral and then contralateral. Okay, this is the view when I want to go on the contralateral side, clearing up over the other side with the lateral leaf of the flavum, remove some fats area, and then some part of the flavum. Okay. Okay. And then this is clearing and checking the area is clean. You see I have cut some part of the SAP that initially pressing over the traversing route here. Okay, now they are all mobile. So in fact, I can I can mobilize the route and can see the disc underneath here. For me, now I like to go ipsilateral. I clean up the contralateral, I'm happy, then I will come and do the ipsilateral. Okay, so again tracing and then cut off the SAP here. So basically there are some pitfalls, tips and tricks as I mentioned. Docking for bony works, bleeding, sometimes we burr with the diamond burr, sometimes the bone so hard you have to use a cutting burr, and then increasing water pressure, but you have to be aware not to increase to certain extent, normally not past 60 for me. Durata, if you see, normally most of the time you can leave it alone, and then sometimes I use the 4.3 millimeter working tube to go to the contralateral side, being aggressively. Okay. And patients can be mobilized immediately after surgery, normally without brace, but I keep telling them no twisting. Okay, at the end of the day, so basically this slide is just to show that what can be done between the uniportal, bilateral decompressions. This is the step, and at the end of the day, this is what we have to do, mobilizing the roots, and then you see there is no lateral lift, SAP remove, and now I believe if there is osteophyte underneath the dura, it has to be removed, because if not, it still provide traction. It pushes the dura tube up, and then it still provides some tractions over the traversing route. So nowadays, if it's big, I remove it. Okay, that's it. Thank you for listening. So there'll be a question and answer shortly.
Yeah, thank you very much, Dr. Azwa. Because of the time, Dr. Azwa, is it okay if we call upon Professor Hisham first, and then we have a discussion if time permitted after?
Yes, I think we should do that.
Okay, again, apologies, very good presentation. And now we call upon Professor Dato Hisham. Is it possible to give the presentation, sir?
Dato Hisham?
Mr. Dato Hisham? Dr. Dato Hisham? Okay, while I think it's still so because of we cannot contact Dr. Hisham, I think we can have a question and answer before, I think, Dr. Azwa.
Okay.
So hopefully we have a 3 minutes discussion. So based on your we see you have a different kind of type of decompression that you are performing. The stando, dry, wet. So for unilateral biportal, do you prefer interlaminar or transforaminal, or do you have a specification in selecting the case, sir?
Okay, definitely for bilateral and involving the central, the better is to do interlaminar, because if you do transforaminal, I still do transforaminal, but if it's one-sided, the transforaminal you can cut, you approach, but you can manage up to the midline. If you cut too much, will extend to the superior part of the facet. You have taken too much of the facet out to see the center of the dura. But one good thing, transforaminal, it can remove big bony osteophyte. Compared to interlaminar, when you have to retract the dura, when we put scope, we can push over to the disc and retract the dura tube sideways, and then we can do disc work and then osteophyte works. That's the advantage actually. So
okay,
interlaminar is still preferable.
Yes, for the gen cases, I think. So how about for the decompression? You need to be able to make sure that it is still stable, in a way preserving the parts. Do you have any tips and trick for that, sir?
Okay. You have like previous Dr. Roni said, where he based on the measurements. But when we do interlaminar work, once we burr superiorly, we burr cephalitely, you can determine the part of the lamina and the outside, which is the lateral part of the lamina, which is nearly the pus. You can determine the border. Okay, you have to know the border. Actually, I have used my dissector to measure, so that to get a wider decompression, I've used my dissector to measure so that I don't pass the diameter of the dissector. If it's too much, then I know I'll already broken the pass, and then this will result later on listhesis.
Okay. Thank you very much, Dr. Azwa. Again, because of the time, thank you very much for the presentation. I think we give a big round of applause online here. And then I will give the time to Dr. Aida, whether we continue to Professor Dr. Hisam or we should go to the next session, because we are sharing this responsibility together, Dr. Aida. So what do you think, Dr. Aida?
Well, it seems like the video is ready.
Yeah.
Perhaps we can just finish it. Yeah.
Thank you very much.
Yeah. Go ahead, Dr.
Thank you. Thank you. I apologize for the interruption. So we shall start where we left off just now. So after we palpate the spinous process, our incision is just slightly lateral to the spinous process. In contrast to the description in textbook, the textbook asks you to put around 3 to 4 centimeter from the midline. But after doing this for a while, we found that placing it at the midline or just lateral to midline is much easier for you to see, especially on the contralateral side. You want less, you distrap the muscle less, because you actually go to the natural plane just beside the spinous process. As you can see through the wound here, you can see now we are already exposing the lumbodorsal fascia. And then after we have seen the lumbodorsal fascia, my microscope now zoom in, you can see the lumbodorsal fascia. I palpate the midline, the spinous process with the tip of the diatomy, and I will make the cut on the lumbodorsal fascia. The cut on the lumbodorsal fascia should be slightly bigger, and now we first put the first dilator, and the first dilator you use it exactly like a cork. So you actually use the dilator just like a cork, separate the muscles from the spinous process, and you progressively insert 2 or 3 size dilator. Once you have done that, right, so now for all practical purpose, on the left side is cranial, midline is midline, you can see there. So now we put our retractor. What is the length of the retractor? The length of the retractor is best measured from the second or the third dilator, because they will sit directly on the bone. And what is the size of the tube? Okay. When you begin, you can use a 20 mm tube. But then if you use a 20 mm tube, because most of these patients have very big spinous process and very big facet joint, you can actually see that the spinous process will be seen on the lateral side of the tube if you use a 20 mm tube. So nowadays we use a 16 mm, or my colleague has started to use a 14 mm tube also to do the decompression. In this way, if you use a 16 or smaller tube, you can actually dock directly on the lamina. Okay, now I adjust my microscope. We can see that is the view that you can see through the microscope. There's a small thin rim of muscle still remain, and this thin rim of muscle we need to just use a diatomy to cauterize that, and at the down there is already your lamina. So this is quite a direct approach. Okay, if you imagine like the first presentation today, you saw the lamina directly, but here only your access is limited.
whatever you do on the inside or at your what we call as at the target side or on the lamina side is still remain the same. So in this video, you can also see that there is no need for us to actually see any part of the facet joint at all if we use a smaller size tube. Like I mentioned earlier, if you use a bigger size tube, you will see part of the facet and you need to be careful not to injure the facet. So this is the view of the fully seen exposed IPC lateral lamina. I use only the 3 mm matchstick head burr. Right, so the sequence of cutting, don't burr in one place, burr homogeneous area, burr over large surface. Don't burr at one place, because if you burr at one place only, you can penetrate all the inner cortex, the middle cancellous part, and the inner cortex, and you may end up with inadvertent dural injury, especially if you use a cutting burr. So this is how much you actually remove the whole lamina. Okay, now you can see that's the cancellous part of the bone. So after you have removed the cancellous part of the bone, you will see the inner cortex of the lamina. And then once you remove the inner cortex of the lamina, you will actually see the ligamentum flavum exposed like this. And we will actually finish off our bony work on the ipsilateral side with the help of the 3 mm or 2 mm Carrison. The next step in this presentation is the very important part, what we call as wanding. You first tilt the table. Wanding is you tilt the tube. Okay, you can see that the tube is slightly tilted. Then you will tilt your table and you will tilt your microscope. By doing this, you will actually be able to see on the contralateral side. So now the tube is being wanded, right? So, okay, you wand the tube. So the tube is already out of the view from the microscope view. Then now, why is being moved? So, okay, now you can see back the view. Right now, you can see we are actually targeting at the base of the spinous process where my arrow is. Then on my diatomy, we remove the small remaining part of the muscle, and this will actually allow you to see the base of the spinous process. This is the key area that you need to identify properly for you to do a very good decompression. So this is the view, right? So the top part is the bone. The inferior part is the ligament. So now we are going to burr this part away. And by burring the base of the spinous process, you actually decompress the central area of the stenosis, and it will allow you to go on the contralateral aspect. So if you saw Dr. Azwa's presentation, the technique is nearly similar. Only the camera is inside, one camera is outside. Whatever we do inside still remain the same, especially with regard to the bony work. So, okay, how much we need to remove on the cranial part? So we need to remove the bone on the cranial part until we can see the inferior, the superior most part of the ligamentum flavum. So you will see that it become detached later on in this presentation. And what you saw in what I'm burring now is actually the inner table of the contralateral lamina. So now, okay, we saw I tilt the table more so that we can see much better. We want our tube again. So you need to do at least 2 times wanding to see on the opposite side. And you can see that's the contralateral lamina. And then we will remove the contralateral lamina at the inner table until we saw the subarticular area. Alright, so that's the bony part that is crucial for you to identify. So now for the bony work, for the bony decompression, and you will see actually the whole contralateral bony work decompress, and you will see the ligamentum flavum from the contralateral side now until the ipsilateral side. So this is the contralateral flavum, ipsilateral flavum, and here in this area is the one that you will see the detachment of the flavum. So if it doesn't detach easily, use a curette at this part here on the superior part to curette the flavum down. So now you can see the flavum already detached, and we will complete the bony work on the contralateral side using a 45 degree or a 90 degree Carrison. Which one that fits you can use. It doesn't really make any difference. And then only you will do a flavectomy. So once you complete the bony work, you will do the flavectomy. Okay, why I remove the flavum on this side first? Okay, so that I can safely retract my dura on this side. I want to give space for my dura sac to move.
At the beginning or only when the trial's in place? Usually just when the trial's in place. Although if I will do an AT and play with the table.
Flavum all remove. So you will remove until all this part is free. And this is how it looks like once you have removed completely. You can start to see the epidural fat to come. There's a good sign. And on this side, where the arrow is the lateral leaf of the flavum. So the next key step that you need to identify is this part, the lateral leaf of the ligamentum flavum. And once you saw the lateral leaf, you put in a dissector, dissect the lateral border of the contralateral root now. This is the part, and you can actually put your suction retractor inside, and then you remove the contralateral leaf. So see how I put my Carrison inside, put it parallel, turn it 90 degrees, and then bite off the contralateral lateral leaf. So now we are going to finish our decompression on the contralateral aspect already. So that's the epidural vein on this side. This is the nerve root. The contralateral nerve root is free, and that's on the contralateral side now. Okay. So you can also put a nerve hook or a dissector to check the extent of the decompression. You need to go down the whole transversing area. And then once that is done, only will come on the ipsilateral side by tilting the microscope. You can come on the ipsilateral side and remove the ipsilateral part of the lateral leaf. Okay, so that's the ipsilateral side. So I retract my transversing nerve root, and then I will remove the ligamentum flavum, the lateral leaf of the flavum on the ipsilateral side. And now you can nearly see that it's nearly completely finished. Okay, if you go more superiorly, you'll be able to see the disc. Now you can see the lateral border of the transversing nerve root there. Where my Carrison is, you can see the disc also visible already. So that completes our decompression. So now we check everything. Ipsilateral side, make sure everything is complete. Contralateral side, make sure everything is complete. And then tilt your microscope to see the superior, and tilt the microscope to see the inferior part. So now you can see a little bit of the flavum still not removed there. So that's why you need to check everything. So this is how it looks like. So once you finish, so don't be a rush to remove the tube. You can see how beautifully all the muscles close, how minimum is the iatrogenic injury to the muscle here. Use this time to secure the bleeding if there is any. Okay. So then only once you secure the bleeder from the muscles, then only you remove the tube completely. So thank you.
Thank you very much, Dr. Dato Hisam, for the presentation. I think apologize, sir, because due to the time, if it is okay, we will give the time to Dr. Aida. Again, appreciate the presentation from Dr. Dato Hisam and Dr. Nurul Azwa. And then I will give the time to Dr. Aida. Thank you very much, sir.
Thanks, Dr. Yuda and Dr. Isham for the presentation. So I will start the last presentation. So just now we talked about uniportal spinal endoscopy, and now Dr. Ajiantoro will talk about biportal spinal endoscopy in treating degenerative lumbar stenosis. Go ahead, Dr. Ajiantoro.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Aida and the committee, MSS and PCI IOSS, joining me for this webinar. I will talk about the endoscopic biportal. First is talk about the endoscopic. Sometimes we find very difficult to start, but I think sooner and later we have to start. I'm very glad in Indonesia there is a senior or a master of the endoscopic can get his experience to young surgeons that can start the endoscopic. And right now, I will talk about the biportal endoscopic spine surgery, UBE, and I will show the three technique with the interlaminar, foraminotomy, and also the fusions with T-leaf.
Good morning, audience. My name is Ajiantoro. I'm from Indonesia. I would like to present biportal spinal endoscopy in treating degenerative lumbar stenosis. I have no disclosure. Canal stenosis, there is a narrowing of the spinal canal where stenosis can occur in the central, lateral recess, or foraminal area. And sagittally occurs due to the decreasing of the disc height caused by degenerative process. The cross-sectional shape classified into three shapes: round, ovoid, and travoid, where the travoid form has the highest risk of the lumbar stenosis. And the symptoms found clinically vary widely, such as low back pain, leg pain, claudications, or motoric problems. The pathology of the stenosis can be divided in the lumbar stenosis due to thickening of the ligamentum flavum, which is characterized by static stenosis, or due to unstable or instability, we call it listhesis, which causes the dynamic stenosis. On these occasions, I will discuss a biportal endoscopic spine surgery procedure for decompression. There are different perspectives on the decompressions, such as open surgery, microscope surgery, endoscopic uniportal, and endoscopic biportal. This is one of the meta-analysis journals by Bin Su from China said that both surgical techniques, uni and biportals, are safe and effective in terms of the length operations, bleeding, and outcomes. But biportals have advantages such as easier for the operator and simpler of tools. The differences between uni and biportals can seem that biportal seems easier to do because it is very similar to open decompression procedures, with both hands having their own duties, has better irrigation flow, a wider view, and slightly more indications such as fusions procedure. This is a technical notes and step of the UBE for decompression lumbar 4-5 vertebra in patients have a central and paracentral stenosis. First is equipment and tower endoscopy like LCD, head camera system, light source, water pump, ablator, and high-speed burr. And for instrument, we can even use a basic spinal decompression instrument for UBE. Setup OT, the important is the positions of patients prone with flex positions to open the lumbar interlaminar space. If the operator in the left side, the monitor should on lower side extremity. If the operator in the right side, the monitor shoot on upper side of the head. The portals, the benchmark is usually a pedicle with a distance approximately 3 centimeters. In the left side, usually I use a mid pedicle benchmark, and the right side, usually I use a slightly inferior of the pedicle because it makes easier for our right hand to carry out backhand procedures. But in my opinion, the important thing is we can get a good triangulations with the C-arm guided. In this case, I did in the left side portals, the marking approximately 3 centimeters in a mid pedicle line. And don't forget to use C-arm guided for epi and lateral projections so we don't get the wrong level. After the incisions, we did a muscle detachments and triangulations. It is very important. Don't be afraid to carry out the massive detachments. The important thing is use a blunt instruments. As long as you are in steel above, the lamina is safe. But carefully in case in the interlaminar space is quite large. Ensure the water flow. The smaller incisions in our endoscope in the left side and good muscle detachment can make the water flow will be smoother. And you can also use a tool such as a sleeve that can open the way of a water. After you did a good muscle detachments, water flow is good, and next is soft tissue ablations. Look at this, you can see a clear view by portals, and then you start in the above of the lamina in superior interlaminar space. Also, you perform in the facet joint, and don't forget to expose the lowest lamina. Don't be afraid you will enter the interlaminar space. The most important thing is use a 90-degree ablator tip. After the view is very good, and then you proceed the bony procedures. I'll start procedures in the lateral side of the lamina, a little bit medial facet joints, from the caudal to cranial, and don't forget to know the isthmus. Don't break the isthmus. It can make some instability. After the lateral finish, going to the medial and contralateral. And for contralateral, usually need a detachment of the contralateral flavum using a dissector to separate flavum from the inner lamina. After that, look for the origin of the flavum border in the cranial side. You can imagine the origin flavum like a lateral eye where the space is on the midline side, and you can look for that side to find it. Begin the extract of the flavum in the insertion along lateral border, lateral recess, and SAP. For flavectomy, this is the illustrations. You can do a piece by piece, or you can do en bloc flavectomy procedure. Release the flavum attachment on the lateral side. Don't forget release of the SAP, and then for contralateral side. Do a flavectomy after the bony procedures is complete. One thing that is important is also release the lower attachment of flavum so that the thecal sac and root clamps can be freed properly. And if you do an en bloc flavectomy, you can probably get a very beautiful flavum like a butterfly wings. After that, you can expose the thecal sac and bilateral roots, and in a decompressed conditions, they will look like a flying kite. And don't forget to check the disc to see if there is a bulging, extrusion disc, or even a calcifications of the disc. UBE can also be used for the foraminectomy procedures. We call it paraspinal UBE for the herniation disc in the foramen. In this case, I did in the L45 from the left side, where the portal marker is also placed in the mid pedicle, but the incisions is made on the lateral side of the pedicle, with the aim of the instrument landing in the isthmus area or a tip of superior facet joint. Clear the anatomy with a good soft tissue detachment, and then you will produce a clear view. Perform the soft tissue ablations until you can get a boundaries between inferior and superior articular process, isthmus and transverse process. Bony procedures is performed from SIP and then towards to the medial of the lamina and to the cranial towards the transverse process. Look for the origins and insertions of the flavum and start from the cranial side close to the armpit of the transverse process. Because there is a gap in the flavum, there to start the phlebotomy. Do a phlebotomy starting from the cranial side because there is open space until you find the exiting route is completely exposed. You can do the ablations with the ablator tip because the access is quite easy and prevent injuring the root. Don't forget to always identify the disc for bulging, extrusions or calcifications. UBE also can be performed to the fusion procedures like a T-leaf. In these patients with the spondylolisthesis L4-5, I did a fusion T-leaf with the UBE. With UBE, we can perform a discectomy, preparations emptied very well, and use a C-arm to place the cage in good positions. Those is result the T-leaf procedures with UBE combinations with the MIS screw stabilizations. This is my serial result for UBE T-leaf that I found the fusion rate evaluated by Girasol criteria, looks the spacer margin, subsidence of the cage, bone within cage, and bone bridge between end plates. And I got only 78%. I don't know why, because the implant use or the instrument, the end plate preparations or water flow. And then we need a further research to know and carry out. The complications that can occur are generally same like others. Infections, dural on root injury, it can be happens. Be careful in severe stenosis, sticky flavum. Manage the dural injury by dural patch or repair if the injury is very large. Epidural hematome formations can be happen. The evaluations is from post-op MRI, but the patients, most of them do not have symptoms, and the risk of infections will higher in the epidural hematome. Conclusions. Biportal technique is a proper choice for surgeons who are familiar to the open surgery. The result surgery is very good. Biportal technique can be widely used. In the good understanding and a good technique, it will make the learning curve faster to be gained. This is one journal about the learning curve said that about 24 cases of single segmental UBE operations are needed to master the UBE. My suggestion is start doing UBE with a simple case. Slowly but surely we will come a UBE master. Don't forget to start with the people near you. So don't be hesitate to look for a mentor near you to see his experiences.
Thank you, Dr. Ajiantoro, for your excellent presentation. It seems that we are quite short of time, so perhaps any questions you can write in the chat, and the secretariat will email to our participants, to our presenters, and they can we can get a response from them and send it back to you all. Dr. Sato, are you ready to share your what was done for your patient?
Yes. Let me share the screen first. Okay, I just would like to recap on the radiograph and MRI images. So radiograph of lumbosacral shows there's a degenerative listhesis L4, L5 with vertebral body sclerosis. There's narrowing of intervertebral disc space L3, L4, L4, L5. There were no fracture, end plate erosion or pedicle erosion. Dynamic film shows no translation over L4, L5. The change in this angle was only 2 degrees. MRI shows L4, L5 foraminal stenosis. And on L3, L4 axial cut showing narrowing of the canal. However, there's no compression over the traversing L4 nerve root. On L4, L5, there is subarticular stenosis compressing the traversing L5 bilateral L5 nerve root. CT scan shows vacuum sign over L4, L5 and L3, L4. So our impression were degenerative spondylolisthesis L4, L5 grade 2 with bilateral subarticular and foraminal stenosis. So I would like to share what was done for this patient. Factors taken into consideration were the main issue for this patient was bilateral L5 radicular pain due to the subarticular stenosis 4-5. There were no back pain. There were no instability pain. There were no translation on dynamic films, and signs of restabilization was seen. Options of treatment was given to patient either fusion surgery or decompression surgery. Patient opted for decompression surgery. We did a posterior decompression L4, L5 spinous process splitting laminectomy. So this was an intra-op image whereby the spinous process were identified and split. Coros detector was used to retract the split spinous process and identify the lamina. Laminectomy and decompression was done in a usual manner. Bilateral L5 traversing nerve root were free. These were II images intraoperatively showing the adequacy of decompression. Spinous process was reattached and sutured using Eti-bond sutures. Post-op CT scan shows there's no worsening of the listhesis and the extent of laminectomy. There were no iatrogenic facetal fracture. Also, MRI was done. The bilateral foraminal stenosis was still there, which was not addressed as patient was not having L4 pain. Adequate central and subarticular decompression were done over L4, L5, and bilateral L5 traversing nerve root were free. Postoperatively, there were no more L5 radicular pain, no back pain. Patient was ambulating without aid and she was satisfied with the outcome of the surgery. Thank you.
Thank you, Dr. Satur. May I invite the speakers back? We have some questions from the participants. So, do you all routinely remove the SAP in your techniques? And if you do, how much do you remove? Perhaps Dato' Isham, you can start first.
I will only remove the just by medial undercutting of the SAP. Like in my patient selection, I already mentioned that I will only do when the facet joint is flat. So in the event that you excessively remove the facet also is not going to be a problem because the inherent stability of the spine is maintained because of the flat facet joint. And when the facet joint is acute, where I foresee that the decompression may create an instability, I will fuse the patient.
Okay, thank you. Dr. Azwar?
Yeah, decompression for me, I just forgot to mention that it just extends cranially up to, you can see the axilla of the origin of the traversing root. So if you can mobilize, you can see the axilla and then the shoulder, basically decompression is enough. So to get that, we normally undermine the SAP. I think that will be enough and then we preserve the stability.
Okay, thank you. How about you, Dr. Haji? Do you routinely remove the SAP?
For me, it depends from the case. If this case only the herniations, even a flavum, I didn't take a flavum in the herniations disc. But if there is some stenosis, I did remove a little bit of the medial SAP, and also I saw the lower border of the laminal and then the inferior in the lateral part. That I have to see the shoulder of the traversing root. So that kind, I will make sure the decompressions is going well.
Okay, great. And there's a question for Dr. Aji. How good is the fusion rate for your endofusion compared with open or with MIS TLIF?
Okay. In my opinions, I did the TLIF with biportals even in the 2 until 3 years ago, and then I found there is only 78% with the Girasol criteria with the fusions levels within the subsidence of the cage. I found there is no healing formations, especially in the outer border. Even I give a pre-grafting. I don't know why, because is it some water flow that make it the substance of the osteoinductive agents or my end plate preparations? But for MIS TLIF, definitely I will do right now MIS TLIF, or even I choose the large cage like ALIF procedure or OLIF procedure for the fusions procedures in this part. Thank you.
There's also another question to all the presenters. Does the severity of the stenosis affect your choice of technique?
Dr. Aida, apologize. I think we have a Professor Chris raising hand here. Professor Chris, maybe you can ask the question directly because it's your question, sir.
Thank you very much to all the presenters for your insightful presentation. My question is with regards to how do you assess whether you are in for a difficult day using your technique? Are there any radiographic features which you would assess? For example, severity of stenosis, if you see any ossification of the flavum, the amount of osteophytes, would you think that these radiographic features would affect your decision whether to proceed with the MIS technique or an open technique? This question is for all presenters.
Can I answer first? For me, if the MRI pathology is dorsal to the dura, then MRI should be enough for me. But if the pathology, there'll be anterior to the dura, which basically bony ossified from the vertebra or thinking of big calcified disc, then CT scan will be better for me. I will take CT scan to know how far do I should decompress and what's the methods of aiming to decompress that particular target. That would be for me.
Okay, for the unilateral with decompression with bilateral approach, the severity of the stenosis does not make any difference. Only thing is that if you do a grade D stenosis, you have to make sure you dissect your flavum properly on the contralateral side, especially in order to prevent dural injury. The extent of the decompression will be very good. The stability is usually preserved provided you follow the things that I mentioned earlier, like the disc height, the stability of the segment on flexion extension x-rays, and the facet joint angle. I would not recommend this for an acute facet joint angle because you may create an instability after the surgery. So to answer the question again by Prof. Chris, No, the extent of the stenosis, whether there is calcification or severe subarticular stenosis, does not make any difference in terms of when you're using a tubular retractor for bilateral decompression via ipsilateral approach. Thank you.
Thank you, Professor. For me, for the radiographic, I always did a MRI for gold standard and flexion extensions. There's some case of listhesis with the stable listhesis that I have to find about how about the edema in the facet joint. Hyperintense lesion is a facet joint. If the hyperintense lesions in the facet joint is not much as 2 millimeters and patients have no low back pain or a dynamic pain, I think the endoscopy can happens to do the decompressions. But don't forget about the foramen. We have to check the foramen in the lateral view and also in the coronal view. But in the point of the patients that the MRI have the herniations, I'll try to do the CT scan because sometimes we cannot have sometimes we have a difficulty to do the MRI to show the calcified of the disc, because if there is a calcified of the disc or the osteophyte can be realized in the CT scan, maybe the planning for the endoscopic will be changed, because the calcifications we have to check about the calcified of the disc or osteophyte that interrupt the nerve very well with the MRI and the CT scan. Thank you.
Yeah, for me, Professor Christian, if we do the microscopic surgery, we see the clearly from the canal and foraminal. So the big problems, thickening of the ligamentum flavum, we do the en bloc flavectomy. Is it enough for decompression of the stenosis? I think for my experience. Thank you.
Thank you very much. Yeah.
Okay. Thank you, everybody. We other questions? So I would like to hand over to Professor Chris Chan for the closing remarks. I think this is an amazing presentation today, sharing of information between Malaysia and Indonesia, and hopefully the first of many combined webinars. Prof. Chris?
I totally agree with what Dr. Aida just mentioned. It has been a very amazing webinar, a very historic event, because this is the first time that we are having collaboration between the Malaysian Spine Society and PCI IOSS. So I would like to thank the president of PCI IOSS, Dr. Gusti Lanang, for agreeing for this collaboration. And I would like to thank all the presenters and also the secretariat of both societies for working very hard to make this event very successful. It is very important to note that the choice of topic for this webinar is L45 stenosis. The reason being that this is an extremely common condition. So this webinar will be relevant to most spine surgeons. Secondly, it is very important to know that we are in a time whereby the surgical techniques are evolving, and therefore we chose this topic, and the 4 presenters have given very excellent talks on 4 different surgical techniques to address the same condition. Although the presentation will not be able to comprehensively cover all aspects of the surgical technique, I believe that the audience would be able to find pearls and diamonds hidden within the presentation within the short duration of time. At the end, I would like to emphasize that our responsibility is to our patients. So do what is best and what is safest in our hands. But do keep learning, because as techniques evolve, it is very important for us to keep to times. So with that, I would like to conclude this webinar. And again, thank you everyone for your active participation. Thank you and have a great weekend.
Just before we end, I think we would like to take a group photo. So if everyone can switch on their cameras for a while, so that the admin can take a photo of this historic event with almost 280 participants. So it's great that we have this many people joining today. Admin, let us know when you're ready to take the photo.
Yes, we are ready. We are taking the photos.
Do we need to pose?
Give us 5 minutes. We are closing everybody.
Professor Chris, we have a pedicle pose. This is a Carrison. Can we go like this, like Dr. Lanang?
Sure.
This is a Carrison pose from PCI.
Sure.
Oh, okay. This,
Doc, please hold on the phone. Thank you, Doc. Thank you, Prof.
Thank you very much, everyone.
Thank you and have a great
Well
week.
done. Yeah.
Thank you.
Thank you, everyone. Thank you for joining.
Yeah, thank you. Yeah.
Okay, bye-bye.
See you next webinar.
Dear esteemed participants, the first MSS PCI IOSS joint webinar has now come to an end. Thank you for your participation. We apologize for the hiccup and inconvenience caused throughout the webinar today, and we appreciate your kind understanding and patience. The e-certificates for this first MSS PCI IOSS joint webinar will be sent to your registered email. And attention to Malaysian participants, following the new system from MMA CPD points will no longer be accredited via QR code. The CPD points will automatically be accredited to only registration participants within 5 working days post-event. Please inform the Secretariat if the CPD points have not reflected to your account after 1st March 2024. You may email any feedback to the MSS Secretariat and we shall respond accordingly. Reminder to those who have not registered for this webinar are not allowed to claim the CPD points. We hope to see you at the next event joint webinar. Have a good weekend and take care.
Huh?